I would say it's our first real mutation or biomarker-directed therapeutic in myelofibrosis, where mutant CALR, as we now know, is aberrantly expressed on the surface of stem cells and the clonal cells. It's not on normal cells. It is targetable by an antibody. Incyte brilliantly developed a Fc-silent antibody that selectively targets the complex of mutant CALR with the TPO receptor. And at least preclinically, it would suggest that it internalizes that complex and you abrogate JAK-STAT signaling. So it all goes back to stopping JAK-STAT signaling. And what we saw preclinically was a very active compound. What we've seen clinically, both in MF and ET, that are CALR mutant, whether it's type 1, type 2, or non-type 1, type 2, is first and foremost very, very safe drug. So we don't see toxicity. I would argue probably one of the safest things that we've used in this context of these diseases. So it doesn't really pose a tolerability issue, which of course is great. And we've dose ramped up from 24 milligrams all the way now to 3,500 milligrams. And we've never hit an MTD. So we know that the antibody can be given. Right now it's every 2 weeks infusion. And what we're seeing clinically is in ET, which is much cleaner, very clear normalization of platelet count. So not dipping down and missing the mark, but you actually normalize it. And what I think is most exciting as someone who's interested in developing therapeutics and the science that drives it is the fact that they've documented in the study reduction in mutant CALR-bearing hematopoietic and stem and progenitor cells. So it's not just reducing the whole blood VAP, it's actually going after the compartment that matters the most, the disease-initiating cells. We see reduction in CALR mutant MEGs in the bone marrow after treatment, and then increase in normal wild-type megakaryocytes. So we're changing hematopoiesis. So I actually think we're on the cusp of seeing fundamental changes in the biology and probably the outcomes of these patients. We need to refine it a little bit more. They're developing a subcutaneous administration of the drug, ultimately probably less frequent than every 2 weeks. We have to figure out some of the kinks of how to choose which patients would be ideal for a phase 3 study. But it's the kind of therapeutic where I could see it being used across the board. If you have a mutant CALR driven disease, the antibody would make a lot of sense. Now, whether we can improve upon it with different antibodies that might bind at different parts of CALR or bites, that's the subject of ongoing clinical investigation. But INCA 33989 has clearly demonstrated that you can safely administer this targeted therapeutic and really exact pretty rapid and significant effects both in ET and myelofibrosis.